giving you the results, but I wanted to address specifically your concerns or what you wanted to discuss at this point.
Okay. So, uh, Mom has a list of questions which we all agreed to. She came up with it, and we all kind of have the same questions. I'm working from a little bit of a disadvantage because my Braille display is currently being repaired. So I'm going to ask her to lead with the questions, and then I'll ask follow-ups if I think of them. And then we can take it from there.
Okay.
I mean, some of it's comments and some of it's going to be questions. We're kind of thinking back through things, and after our appointment with Dr. Flaherty and stuff, Chris used to have night terrors. Do you believe that all of this started when he was way younger? Is there any way to kind of know or not know, or?
I wouldn't know. I mean, it's common for kids to have night terrors. That's a common.
Yeah, so there's some things we used to notice, like shivers, which I'm now kind of being retrospective, kind of going, maybe that was more myoclonics and stuff like that. So I was just curious.
Okay.
Is there any way to know if from the EEG, I mean, I know we're having, the grand miles and stuff like that, tonic-clonics. Is he having any focal seizures also? You're not seeing any at all?
No.
Okay.
From the EEGs.
Okay. And because, again, being very hyper vigilant right now, and there's some days when he has seemed a little off, and we had an evening where he was just like, and like I said, with the blindness, it kind of gets a little confusing in here. He was just perfectly still, staring, not blinking, and again, doesn't blink quite as often as I do anyway, so we've been sort of trying to figure out if it.
Uh-oh.
I haven't seen anything focal on the EEGs. They've always been this generalized epileptiform activity. There's never been anything focal, and there's never been any seizures on the EEG.
Okay. I mean, the EEGs are only in a limited amount of time. We know that, but I guess all we have to work from is what little we know and what you've been able to see from the scans, and I can say what I've noticed and what they've noticed is there have been times when I've kind of spaced out, I guess, is how I can describe it. And the eye movement, I mean, I don't know. I have prosthetic eyes, so so I'm not totally surprised by not blinking, but I can say that there have been times when I've just like spaced out momentarily and I've had to like regroup, and so that's a relatively recent development. And that might be the one thing that would lead me to ask that question, and that's something that the epilepsy community that I'm connected with has described as a symptom of focal seizures. So that would be the thing that would lead me to that observation and that question.
No. So I'm gonna take a step back. So
Okay.
Because you're staring or unresponsive, that doesn't mean that your seizures are focal.
Okay.
There are staring and unresponsive events that are also generalized seizures, and they don't have to be focal seizures. So I wouldn't say that, you spacing out has to be the indication of a focal seizure. No.
Okay. So
right?
maybe
People
we're,
come to me and say somebody has absence epilepsy, or they have absence seizures, or staring and unresponsiveness. I'd rather you say you have staring and unresponsiveness, because it could be absence epilepsy, which is the staring with the eye blinking, or it could be focal seizures. So you can, but staring with the eye blinking and absence epilepsy is generalized epilepsy. So they can both look the same and have a different root cause, right? And be a different type of epilepsy,
okay.
right? I haven't seen, at least when you push the button, it wasn't any indication that that was what was going on as far as the behavior. Let me go back and look. That would be the only way that I would know specifically the behavior, if the behavior was a seizure. But on your EEG, there were no seizures. There's only those epileptiform discharges. Do you have focal events, focal seizures? No, you have a generalized epilepsy.
Okay.
Okay. Does that make sense?
Yeah, that makes sense. So it was,
Okay.
I guess we were confusing terms. Okay.
Right.
All right. I kept getting kicked out. I got off my
Yes.
Wi-Fi, so hopefully that'll fix the problem. I don't know.
Okay.
So,
Good.
where is our max for Keppra? I mean, we're at a pretty high dose now.
Pretty high dose. Usually max the Keppra is 2,000 twice a day. That's usually what I
Okay.
take.
Okay, so we're kind of there.
And that's, yeah, that's where we're at.
So
Yeah.
what are our if we keep kind of going down these paths, where are we headed?
So we probably maximize them all. So right now, you're almost there with Keppra. I think you're at 15. I was going back, sorry, and looking at the EEGs. I don't see any behavior of the staring and unresponsiveness, so I can't tell you if that specific behavior was a seizure, but we didn't see any seizures regardless of if you noted the behavior on the EEG. And I don't think that, I doubt that you have focal seizures just because you could be staring. But at least as of right now, everything points to the direction of generalized seizures. Circling back to the medications. So basically with Keppra, there would be, you're at 2,000 twice a day, so you're there. With zonisamide, I think you're one capsule off, because usually that one's 600.
Mhm.
So you're taking 2 in the morning and 3 in the evening of that one. And so it'll be 3 and 3. And then lamotrigine, usually that's about 300 milligrams. So
Okay.
you just started that at 50 milligrams. The other path forward would be considering like a VNS, a vagal nerve stimulator.
Okay. We had discussed that at one point at this end, and we were not sure whether that was even something, we had never kind of talked about that, any of us. So is he
How
a
would that
candidate
work?
for that?
So for generalized epilepsy, he could be a candidate for it. It's the only device that we have that treats generalized epilepsy. And so that's the only other option we have, right? Besides medications. That's it. And so if you're talking about another medication, since you tend to have big seizures, the big shaking convulsion, the only other medication that I would think about would be Xcopri or cenobamate, because it's use that because that's focal onset epilepsy, so never mind. You can think about Onfi, you might qualify for that, but I wouldn't want to use older school medications like Depakote or something to that extent. So we're probably looking at a device, which the vagal nerve stimulator is the only one. It sits in your chest, sort of like a pacemaker sits in your chest wall. It goes like underneath the skin, right above the muscle, so underneath the fascia and stuff. So you can feel it, you don't really see it. It tunnels underneath the neck and basically goes, and it has a wire that wraps around the vagus nerve. The vagus nerve traverses from the apex of your heart to the base of your skull, externally, from until it goes into the brain and that part of it, right? So basically what happens with this is that it has stimulation that works for 24 hours a day. It's on for a period of time, off for a period of time, and it just continuously does that. And then you see me, and we'll increase the basically change the parameters of the stimulation.
Is that in addition to or in place of the medication?
Medicine.
Okay.
It's in addition to medicine, right?
Okay.
So it's almost it's like an adjunct. It's like another medication.
Okay.
Okay.
Would that be, sorry,
Go ahead. Go ahead, Craig.
would,
Sorry.
would that have meds though at the same dose?
It may not, but in the beginning, we would not change your meds.
Okay.
Right? It takes a while to titrate it to a therapeutic range. It takes a while to see your response to it. And especially because you typically, although more recently, you typically don't have seizures that often, right?
Right.
So I would respond like for a person that has seizures every month and over a 4-month period, I would be able to look at the frequency of their seizures during that time and make an adjustment, right? Yours is a little bit trickier because your seizures are less often.
Right.
So I wouldn't want to go in and keep programming and keep, hitting you with more stimulation until I can see that it's having what kind of effect it's having.
Gotcha.
Okay.
Okay. And I just want to double back. The lamotrigine.
Yes,
You
ma'am.
said you maxed out where with that?
300 milligrams. So he's at 50, I believe. Is that correct? He's taking half. What's he taking?
He's taking
300.
300 in the evening, 350.
That's right. 300 twice a day. Yes, ma'am.
Yep, 350 in the evenings.
And so that's why it has it. They're missing that other 300 milligrams. So they just gave me the 50. Somebody took out my 300 milligram dose. I need to add that back before it gets lost into the ether. Give me a second. Because that will happen. So yes. So what happens is that basically we looked at his labs, and with his labs, he was, based on the levels, he was able to increase it a little bit more. So that's why we increased the lamotrigine. The only one that I would feel comfortable maximizing at this point is the zonisamide. I think we've maximized the other ones.
Okay. And so with the blood test that you do, even though we have a specific for the Keppra, you're checking all of them.
Yes, ma'am.
Okay. The Keppra just has special order, right?
That one was a special order before because it was supra therapeutic, but it was depending on the time that he took it. So you notice that when he took it at the right time, had it drawn at the right time, that the level was more appropriate. So that's why I did that, because I was more concerned because I think we had recently increased the Keppra.
Okay.
That makes sense?
Yep.
Okay.
His kidney functions are showing high, not super, but high. Is all of I know there's lots of warnings with all these medications. Are we doing damage here?
So no. So the only medication that is excreted by the kidney is the Keppra. Keppra does not affect your kidney. So basically, if his kidney function is abnormal and it shows that his filtration rate, so the way that he filters out substances, is inappropriate, so it's low, then that means that we can't put him on the dose of Keppra that he's currently taking. Okay. We have to adjust the dose based on that number, on the filtration of your kidneys.
Okay. So are any of these medications messing with other organs, or is that
They do. They mess with the liver. So basically, your liver is metabolizing all of your other medications, your zonisamide, as well as your lamotrigine. So with that, we look at the liver function, which is what we did before, and the liver function looks stable.
Okay. All right. You had a comment in your report from the MRI concerning white brain matter, but equal with 25-year-olds. There was some questions involved whether that was like a healthy 25-year-old or a 25-year-old with epilepsy. Just wanted to, sort of understand that comment a little bit better.
So he had white matter disease, around unchanged. It's still there. If it had changed and increased, I would be worried. It hasn't changed over the past 2 years. So I don't know where it's from. I don't know if it was from birth or, but it's been there. So that wasn't alarming for me.
Okay. He had a frontal lobe and a cerebellum bleed as an infant.
So that white matter change is from that.
Okay. I mean, again, we're everybody's researching and involved in groups and stuff like that, so we come to you with those questions. I see a lot with extended EEGs and EEGs in the hospital, looking for. Will that give us any information? Why are those done? Why are we not doing them?
Gotcha. So basically, those are done either as diagnostic, either I want to define what type of seizures they have or what type of behavior, right? So say the eye blinking and the staring became more often and we couldn't capture it on ambulatory, then I would say, okay, bring them into the epilepsy monitoring unit and look and see if this behavior, if we can capture it and see if there's any EEG changes while that behavior occurs. So you're able to say, is it actually seizure related or is it just behavior, right? So that's one reason why you bring a person in. You're trying to diagnose an event or characterize an event. Another one is that basically you're thinking about epilepsy surgery, so you're taking them off of their meds, you're capturing as many seizures as possible so you can see the onset of their seizures and then basically know where you have to either excise that area, put in wires or whatever else way that you're treating it.
So if we go for the VNS, then
you don't have to do that.
We wouldn't
because
have to.
VNS is external. It's not having a wire placed exactly where the onset of the seizures are, right? And his onset of the seizures are everywhere. We can't place a wire everywhere.
Okay.
Okay.
Any experience, knowledge why this got so bad so fast and late that day?
I don't know. I mean, everybody has their own individual course. So there sometimes is no rhyme or reason of why that happens. Some people, it's bad in childhood and over time it dissipates and it gets better. Sometimes it completely resolves. Some are worse as, you age. If I had that crystal ball, I'd be a very rich physician. But I don't.
I mean, we've kind of gone, like you said, from every once in a while and him coming out of them. I mean, his last, it's October. He has needed rescue meds every time.
Yep. Which is different, very different, right?
Yeah.
So that's why I said, the vagal nerve stimulator might be better because you can stimulate, try to, give that magnet and try to help bring them out. If it doesn't bring it out, sometimes it can reduce the severity or the post-ictal period. Sometimes if you have that aura, if you can tell, people swipe it then to try to prevent it from progressing. So there are different ways that, people use the magnet and use the device.
Okay. All right. Yeah. Needless to say, the last one on that third day when we were fighting to get the rescue meds here, I'd rather not have to do that ever again. And then my last question that I have on my list is, we have been in touch, and I think we've talked about this with CBD. We do our contact with the friend and professional. The last conversation, and Chris, you're going to need to step in here a little bit, that Chris and Dawn had, is Dawn would like to be able to meet with you and work in conjunction with you to get him at good levels and see if this is an option for us.
Yeah.
Okay.
Yes. Yes. Sorry.
So I don't work with CBD at all. I'm just gonna, when you guys came to clinic, I said that that's a separate entity. Whether it's, you find someone that works with you and you prescribe that, my only thought is that, making sure that it's not going to interfere with your liver, with the other meds, which is another reason why I'm glad we got drug levels before, starting CBD, so we can see how things are. I don't, and I'm just going to be frank, I don't do work with CBD at all. The only closest thing I come with CBD is prescribing Epidiolex.
Okay, my interpretation of what Dawn was telling me is, as a medical professional, she just wants to be in close contact with you as my neurologist to make sure that you're both collaborating, communicating, I guess, because you're both working on medical things and my medical plan. And so I, and I agree that that I would want that to happen, and what I was hearing from her is she doesn't want to touch something involving something as sensitive as epilepsy if she doesn't communicate with you. And so I agree with her that I would want her to excuse me, to be able to communicate with you. So that's what the question was about.
She can communicate with me, and I'm gonna be as frank because I haven't been any other way, right?
Right.
So I talked to you guys before. I let you know if you want to do CBD, that's totally up to you. Patients that want to do CBD, that's totally up to them. I don't become involved with it because you're asking me. I don't believe in it.
Oh.
Why don't I? Because anecdotally, patients have told me that some have fared better, some have fared worse. But the amount of CBD that's required and what I've seen from evidence-based medicine to actually treat the seizures is like 100-fold greater than what you're getting over the counter. So if but I'm not going to say as your physician that you can't try that, right? If you want to, but if you're asking me my evidence-based opinion about it, that's what it is.
Right. I know that CBD can also help with anxieties and that mood. And I guess I step back to things when things bad in January was right after our meeting with Dr. And some of the news that I think she shared was a little disheartening. There was move decisions for Chris, some adult decisions. And I guess I tend to wonder whether stress definitely is a trigger for Chris.
Right.
And whether can help in that area. But like Chris is saying and Dawn is saying, we just don't, we don't want to overstep the medical side and do damage there too. So I think that's why she's hoping to at least be able to be in contact with you. So if you're willing to how do we do that? We have HIPAA agreement. You and she can talk. We do a call like this she's involved in.
You can do a call like this, and as long as you guys want to be involved in and have her there, that's fine with me. But when it comes to about my expertise in managing what she should do or how it's going to interplay with my medicines, I'm not going to do that. That's my staunch, just what I'm going to do as a physician and what I'm not going to do as a physician. Understood. And so my thing is that when it comes to anxiety, that's outside my field house. I don't know what how it works or, what doses would work with anxiety. I stay within my epilepsy box and I look at the research within my epilepsy box. And, I can tell you within my epilepsy box what it is and what isn't. And Chris, you can't see me making a box, but
I got you. I got you.
So, I try to be up to par and up to date on as much information that's going to be beneficial to my patients as possible. Mm-hmm. So, and like I said, anecdotally, have patients come to me and say, yes, me taking over-the-counter CBD is helpful. And then I'm like, great, do what works for you. As far as the evidence base of what we can see, that's something different. So, gotcha. Okay. All right. Chris, I went through my list. Do you have a question? Do you need additional clarification on anything?
One more clarification question about the vagal nerve stimulator. I guess ideally for me, and I don't know if any of us does, whether this is going to happen. But ideally, I would love for eventually us to get to the point where my Keppra or other meds can be lowered and don't have to be maxed out. And if that means the vagal nerve stimulator, great. But where we are now, understanding that there isn't really a pattern to my meds, but also understanding that there isn't a pattern to epilepsy. It's idiopathic, as my primary care gave me the term for it last time I saw him. Do you think overall, that the VNS is worth it. What's your recommendation for that?
So I've seen it be beneficial with many patients. I would say that, you know, what I said in the beginning still stands. You still take the same number of medications, ultimately with the goal of reducing or possibly removing a medication or two. That's always the goal. It's just that as we traverse through that and programming, you know, we have to look at over time, just like with the medications over time, what's going to be helpful and what's not. So I liken it. I like it. I compare it similar to a medication in that, you know, you take your time, you adjust it, you see if there are side effects, you see if it's working, and then you make those changes based off of that.
Okay.
At what point do we decide whether this is a path we move in? I mean,
I think we're almost at that point. I broached it down and brought it to you so you guys can think about if that's something that you want to do, because basically we're one step from maximizing out Zonisamide.
yeah, when he was in the hospital and they asked me to confirm the meds on the screen and it's flashing at the bottom, high amount. I was like, great.
Yeah.
Okay. So basically you're saying the family needs to discuss this, and if it's something we want to move forward with, then now's sort of the time, not
Yes.
waiting around to see. Okay. Okay. All right. Anybody else?
That's all I've got.
All right.
All right. So I think we have already scheduled a point. I hope we do. Let's let me look.
December something. I
No.
think. No.
Oh wow. Wait a minute. We did today, and then you have a neuropsych one in May, right?
Uh-huh.
So if you decide to have
Yes.
it placed, then what we'll do is that we'll schedule one after you have it placed so we can start programming.
Programming what?
Programming the device. If you decide to have it
Oh, I see. Okay. Sorry.
programming on me.
Okay.
Surgery, so are we talking this is an outpatient thing?
It's outpatient day surgery. I would need to make an appointment to send the consult order to Dr. Sather. He does all of our surgeries, whether that's brain surgery, whether that's BNS, he does them all. And so it's an outpatient, few hours, go home the same day. Basically, you come back within a month, and then we start programming the device.
Okay, and what? So I just again with everything that has happened, Chris is now living much further from her.
Right. So that's you know, I would take, because the seizures haven't been as frequent except for here recently. I would say that, you know, taking the time on a 3 to 4 month basis just to program it and see if there's changes over that time is it seems adequate.
Okay. All right. Chris, you good?
I'm good.
All right. Dr. Fisher, thank you. We appreciate it as always.
Of course.
Thank you so
And then
much.
you guys let me know about either the device or another visit if one is needed during, you know how to get this. If you're not there. Okay.
Okay.
All right. You guys take care.
All right. Thanks. You too.
All right. Bye-bye.
Bye. Okay.
So when did you guys start talking about this ATV thing?
This which?
The vagal stimulator.
I think she brought it up in one appointment like a couple of years ago, and it was something I vaguely remember hearing her say something about, and it was honestly what I remember when she said something about it was a conversation in a Facebook group.
Oh, okay.
But
It sounded like this is a discussion that's been fairly recent.
no,
Okay.
Not-
So this is the
not
first
as-
time you're like hearing
not
about it.
not as far as I can remember.
Okay.
It was when she said it, I was like, oh, that thing.
Okay.
And that's why I asked the question. I asked, what's that thing again? So, so yeah, I had to be reminded of what that thing is, and I think I still need to read up on it.
Well, it sounds pretty straightforward, which is good. I mean, it's less invasive than, brain surgery.
Right.
That's a good thing.
But it's still it seems, if I'm understanding her correctly, it's an implant.
It's an implant that goes under your chest, it'll just sit right under the skin on the muscle, and then there'll be a wire that wraps that vagal nerve, and it sounds like there's a magnet. So instead of taking a pill or an inhaler, you have a magnet, and you swipe the magnet across the thing on your chest. So if you had a magnet, you just kind of go like this, and it would stimulate. That's how it's like my oven, my stovetop.
Yeah.
It's a magnetic transfer, and that's
So where's the magnet?
the magnet's on you.
Okay.
So that could be in your medication bag.
Oh, okay.
I'm guessing.
So okay.
I'm guessing it could be a magnetic that you could wear on your arm, like in a band, and you just take it off and swipe it, or put your wrist up there.
Like
I don't know.
on my band where my watch is.
Yeah, I don't know.
Okay.
I'm sure they have some fancy way to do it, a practical way to do it, because
Okay.
you can't be searching the house for a magnet when you're having a.
Right. Right. So,
Yeah.
but it's easier to swipe a magnet than it is to inject
Oh,
rescue
absolutely.
meds.
Absolutely. Well, and you're trying to prevent getting to that point.
Right.
So that's good.
So, hello?
How's it going?
Oh,